Hello and welcome. My name is Tim Poe. I'm Director of Telehealth with the UNC Cancer Network. It's November 27th, 2017, a Monday, and I want to welcome you to our UNC Cancer Network lecture series. This is for community colleges, and this is our oncology lecture series. So thank you and welcome. If you're having any technical difficulties at all, please go ahead and give us a call, 919-445-1000. We have technical assistants standing by. You can also email us at unccn@unc.edu. You can find us on the web at unccn.org. We're on Facebook, we're on Twitter, we're on YouTube. So we hope you'll visit us in some or all of those places. But again, if you're having any problems at all technically, reach out to us right now, please, so that we can get those worked out for this afternoon's lecture. All right, we are going to start off with a poll question, and I hope that everyone will go ahead and answer this. You can answer this completely anonymously. The question is, according to the 2015 statistics from the National Hospice and Palliative Care Organization, what percentage of Medicare hospice patients had a principal diagnosis of cancer? So really we're looking for, do you think this is a large percentage? Do you think this is a small percentage? A would be 9, B would be 11, C would be 19, and D would be 28. So the way you can do this is, and I'll give you two ways you can answer this poll, and this is important because this is the same thing that we'll do for our question and answer session at the end of today's lecture. So you can either go on the web, through your phone, through a laptop, etc., to pollev.com/UNCCN. You'll see the poll. You can put in A, B, C, or D, and in just a moment we'll see it in real time along with the answers from the other people participating. The other way you can do this is if you have a phone that has texting capabilities, you text the number 22333 with the letters UNCCN. You just need to do that once to join today. Once you've done that, you'll be ready to ask questions at the end, and you can be jotting those down, thinking about those while you're listening to our presenter. So again, text the letters UNCCN to the number 22333. You'll get a little message back that says join, and then you can say A, B, C, or D, depending on whether you think that's 9, 11%, 19%, or 28%, and we'll see what your answer is. All right. Our guest today is Dr. Chrissy Kistler, and she's an MD, and she also has a master's in applied science, and she's an assistant professor with dual appointments in the Division of Geriatric Medicine and the Department of Family Medicine at the UNC School of Medicine in Chapel Hill. She also serves as the medical director for the REACH program at UNC, a patient home care service sponsored by UNC Family Medicine. Dr. Kistler's clinical area of interest is decision-making around the care of older adults, particularly the appropriateness of their care. Her research focuses primarily on preventative services such as cancer screening, tobacco cessation, and infection control. So with that, I want to say welcome. Thank you so much for being here today.
Thank you for having me.
Absolutely. So and we already have those poll answers coming in, so that's great. We'll give folks just another minute to respond. And while we're waiting for that, what led to your interest in palliative care, the subject of today's discussion?
Yes, so I did a fellowship at UCSF in geriatrics, and as part of that time we do, as part of our fellowship, we spend time on the palliative care service.
Great.
And while I was there, I began to notice that a lot of our patients, even when I was on the general geriatric service on family medicine, have a lot of uncontrolled symptoms, and they really struggle with how to make decisions that are sort of that agree with their values. Yeah. And so as part of that, I felt called to kind of do that work. So I took my boards and got grandfathered in, and I attend at the cancer hospital now about 6 to 10 weeks a year.
Great. Well, we're fortunate that you do, and we're looking forward to hearing you speak on this topic. So what do you think? How did they do? We've got our lowest responses in that 9% category, and we have over half of our people responding at that D or 28%.
Yeah, they did good. That's excellent.
Good. So that is all right. So we're at that 28%.
Yeah, it's a lot.
Yeah. Well, end-of-life care options for patients with cancer. So I will turn the keyboard and the mouse over to you.
Perfect. Thank you so much.
All right. Thank you.
All right. I hope everyone can hear me. Let me know if you're having any issues, but we're going to go ahead and get started. This is Dame Cecily Saunders. She's the founder of the hospice movement. It came out of England, and she actually was a nurse, but actually felt that and was told that to get really cred on the street, she needed to go back and get her MD, which I think is sad because I love nurses, but she did. And her perspective was that what matters to people is them and what is their lives, and that we need to help people live throughout the course of their life, and that includes up until the moment of death. So today I'm going to be talking about four main things. I'm going to first spend a little bit of time talking about how teamwork enhances quality of end-of-life care for cancer patients. I'm then going to talk about what the differences are between palliative care, which I think of as more of a larger umbrella and a slightly different perspective, and hospice, which is really in those last 6 months of life. Then I'm going to actually talk about some pragmatics and the logistics of palliative care and hospice, and provide you with some resources that are available to patients and families to learn more about these services. So I think it's important for you to understand what various terms mean when we're talking about end-of-life care. First is we often talk about end of life, but I think it's better to approach it as serious illness, because we're not great prognosticators. Many people, we think, oh, you've got months, and then they have days, and oh, you've got months, and then they have decades. And so I think it's important to just ask yourself, does this person have a serious illness that is not curable, that may be life-limiting, and is definitely life-altering? We also talk about palliative care. Palliative care is at its core an interdisciplinary care to improve the quality of life for patients living with these serious illnesses, and also for their families. We talk about supportive care. These are community-based care to meet emotional, spiritual, and practical needs. So supportive care can be psychiatry, psychology, it can be chaplain, it can sort of span the spectrum of support that people need. And then hospice care is really interdisciplinary care focused exclusively on comfort in those expected to have 6 months to live or less. I think it's important that no matter what kind of care we are talking about, we are not saying to people, there is nothing more that we can do for you, because there is. We can always help control symptoms, even if we cannot prolong life. And that when we say treatment is futile, we may say treatment is futile towards prolonging life, but treatment of symptoms is not futile. So that's a term that we don't like to use. We don't like talking about withdrawing care. We shift the focus of care, and we can aggressively manage symptoms, just like people get aggressively managed in an ICU for whatever disease process they have. And again, we don't tend to use the term comfort care unless we're really talking about in the hospital where people go on comfort care, because comfort is something that should hopefully be happening across the spectrum of disease. So let's first talk about teamwork in end-of-life care for cancer patients in particular. Now, we know that ASCO, which is the American Society of Clinical Oncology, so it's all the big oncology groups that have this large association, they promote interdisciplinary teamwork as the gold standard of cancer care. So all cancer patients across the cancer continuum should have interdisciplinary teamwork. And that includes, and we'll talk a little bit about what that includes. And what we know is that when we involve people, not just the docs, but we have the physical therapists and the nurses and the pharmacists and everybody involved in that care, that we get better clinical outcomes and process outcomes for our patients. And that one of the ways we do that is because it helps bring consistency to the communication between the team and the patient. And when we talk about who are on these teams, of course there are oncologists on these teams, and sometimes there's surgical oncologists and the radiation oncologists and the medical oncologists. Great. But there are also, like I said, pharmacists, there's psychosocial care, so psychologists, social workers, there's physical therapy, there are oncologic nurses. And so everyone has a role in the care of these cancer patients. And what we find is that teamwork has hard benefits to our patients. It has actual tangible outcomes that help patients. It improves the planning of their therapy. So we know that, okay, I'm going to give you your surgery first, and then I'm going to follow it up with your radiation, and then at that time I'm going to start your chemo, but then your chemo is going to go on. And throughout that process, I'm going to have the pharmacist helping manage this. I'm going to have the social workers helping manage your care at home. I'm going to have the nurses who understand what the care plan is, so you're getting the right medicines. And so it improves the planning of therapies. It improves the pain control. And many cancer patients have pain. And so helping them manage that is key to helping them maintain their function and improve the quality of their lives. It helps them adhere to recommendations about their preoperative assessment. So before they're going into the OR, and make sure that everything is sort of taken care of. And it helps them manage their medications. There are still other outcomes in terms of mortality, in terms of other types of morbidity, which we don't currently have evidence for, but we strongly suspect that it helps those as well. And that patients perceive that it benefits them. So not does it just benefit the clinical team, but it also benefits patients. They feel that they have higher rates of prompt access to care. They rate their patient-professional communication higher. They feel that people sort of treat their team, that it's a person-centered response to care, and it really helps improve continuity of care along the care continuum. So again, care teamwork is important, and that is important in palliative care and hospice as well. We're next going to be talking about the differences between palliative care and hospice. So it's important to remember palliative care is not hospice. So when people talk about palliative care, they're not saying I have 6 months left to live or less. Okay, people can get palliative care across the spectrum. So for example, I recommend using your third wish to prevent joint pain in later years. So we might palliate joint pain. There are lots of things that we palliate, that is, we alleviate suffering, and people aren't dying from their conditions. So what is palliative care? As I said before, palliative care is an interdisciplinary care to provide comfort and quality of life for a person with serious illness and for their families. And that includes pain and symptom management. It includes support for decision making. Many of our patients are facing very difficult, complex decisions about their care, and they need support, and palliative care can provide support. And it also provides emotional, spiritual, and practical support, because going through cancer, facing the loss of independence, facing other sort of threats to my personhood can be very challenging, and therefore people need that spiritual and emotional support that palliative care can offer. We know a lot of patients would likely benefit from palliative care. 2.6 million patients died in 2016. About a quarter of those are from cancer. And we know that cancer is, if you don't die of your heart, if you don't die of your dementia, cancer is right up there with heart disease as the #1 killer in this country. And so then who delivers palliative care? Now, obviously, they're palliative care teams. I work on a specialty team in the hospital. We have physicians like myself. We have nurse practitioners. Sometimes they're nurses. We have a social worker. We have a pharmacist that we pair up with, and we have a chaplain. There are hospice teams. So hospice can sometimes provide palliative care. So many hospices will have their primary core hospice activities, but then they also have a palliative care arm. And again, those tend to have nursing, social work, maybe some aides, so nursing assistants and chaplains. But I'll be honest, I think palliative care can be provided by physicians and nurse practitioners that are primary care providers. That includes oncologists. I think physical therapists can provide palliative care. I think nurses can provide palliative care. That is, the things that we do that alleviate suffering are palliative by their very nature. So, like I said before, there are things that palliative care is not. It is not comfort care only. It is not, we're going to withdraw care. It's not, we're not going to be aggressive anymore. Yes, we're not going to be aggressive by like putting you in an ICU and putting a central line in you and pumping you full of fluids and pressors, but we're still going to be aggressive in making sure your pain is well controlled, your dyspnea is well controlled. We're still going to diurese you. We're still going to give you medications to help manage that. When people say we're not going to do anything for you anymore, I think that is not what palliative care is. Palliative care is symptom-based care, and it's not just, okay, now we started morphine drip on you. So when we think about life, we have on your left, you have when you're born, and over at the far end, we have death. What we know is that that little bit at the end, that is, and here I'll use my marker, this is hospice, okay? These are where people are on hospice. However, let's see if I can move it forward. We also know that people are going to need care after hospice, and people are going to need palliation of their symptoms even before they enter hospice. So here, yes, we're working on curing your cancer. We're working on managing your diseases. But as we go, we are going to have times where we're probably going to manage your symptoms more, maybe less. And so this line actually probably needs to be a little wavy. Until people find that our treatments have failed them. Patients don't fail their chemo fails them. And I think these words are important that we use. And so when their chemo has failed them, when surgery is not an option anymore, then they can move into to hospice at that point. But their families and their loved ones are going to need bereavement care even after they die. So this is sort of the spectrum, the continuum of palliative care into hospice. So who are we talking about? We're talking about those people with serious illness, critical illness with high burdens of suffering. People can be eligible at all stages of their life for palliative care. So we have, children, some with cancer or even some without, who have a high symptom burden that we need to manage. Pregnant women who are throwing up all over the place are going to have a high symptom burden and need palliative care. People in older ages who may not have a discrete condition, but sort of the multi-morbid state that they're in are going to need palliative care. And then those people, again, who qualify for hospice are going to get palliative care, and the focus is solely going to be on their comfort. So why is this important? Again, palliative care is frequently misconstrued as synonymous with end-of-life care and hospice. It is important throughout the course of their illness. We know that 75% of deaths in first world countries are caused by progressive advanced chronic conditions, which are going to be high symptom burden conditions. We know that just like with team-based care and oncology, when we look at palliative care, we find palliative care, again, as a team-based way to care for people, improves patient satisfaction, pain, dignity, communication. It actually improves compliance with treatment, earlier consultation, so people get their diagnosis of stage 4 cancer and they get a palliative care consult. Those people have higher rates of satisfaction. It also improves healthcare costs, so people tend to not like to live in a hospital. And if we can manage your symptoms, you're not going to come into the hospital as much. So again, this also helps us document treatments so that the daughter or the wife are not feeling like I'm doing things to my loved one that they wouldn't want. We can get their preferences down, and we can make sure that we honor those preferences throughout the course of the disease process. So again, we know randomized controlled trial. There was a wonderful trial published in New England Journal of Medicine that showed that early palliative care co-management versus standard cancer care improved quality of life. It reduced depression, and it reduced aggressiveness of care. That is, people who were getting chemo within 2 weeks of death. And it improved survival. So people who get palliative care live longer than people who don't. And I think that is something many people don't understand. This is the seminal paper, one of the seminal papers published in New England Journal on early palliative care for patients with metastatic lung cancer. And again, it also found that early integration of palliative care in these patients with non-small cell lung cancer improved survival by 2 months, as opposed to 3 months, but 2 months in this case. It improved quality of life and mood. It improved greater documentation of resuscitation preferences. And so people who want to get resuscitated do get resuscitated, and people who don't. It also tended to provide less aggressive care at the end of life, and I think sometimes people get in this cycle of, well, I was treating, I should continue to treat. I need to focus on the disease as opposed to focusing on the person and their values. These are the actual survival curves, and you can see the split happens fairly early, though benefits even out as they get older. So that's what I'm talking about here. So these lines diverge. And so we see these people survive more than these people. The American Society of Clinical Oncology came out with an opinion that all of oncologists should adhere to, and that is that palliative care should be integrated into standard oncologic care for all the reasons that we talked about before. And so again, here's a summary before we move on to talk about hospice care. Palliative care is the specialized medical care for people living with serious illness, many of whom will see physical therapy, allied health professionals, and physicians. The focus is on providing relief from the symptoms and the stress of a serious illness. It helps with medical decision making, and it offers support to patients and families, whatever their diagnosis may be. The goal is to improve quality of life for both the patient and the family using an interdisciplinary team-based approach. And it is appropriate really at any stage in chronic illness. I like this comic cartoon. You've got 6 months, but with aggressive treatment, we can help make that seem much longer. So where do people die? Currently in the United States, and this data is a little late, but we don't have, this is the most current data that we have, that among older adults, most people die either in the hospital or at home, though about a quarter of people die in long-term care, that is a skilled nursing facility, and about a fourth of them have stayed in the ICU, and that even includes people who've been on hospice. And so, but when you ask people, where do people, so this is where people die in relationship to the hospital, we see that even though they are dying on readmission to the hospital, that's only about 7.1%. 15.8% die within 30 days after hospitalization. About, again, 17% die in the hospital, and, 15% die greater than 30 days after hospitalization. Almost a quarter of people die within 30 days of a hospitalization, and about a third of people die with no hospitalization. But a hospital tends to be a place where people who are near death or actually die, travel through. So hospitalization is one of these key flags for patients. And what we find is that when we ask people, where do you want to die? Most people prefer, looking back on a death, they rate the hospice as sort of the highest level of care. They then rate hospitals not quite, and then people who are just out in the community, are seeing their regular doctors, that's less, and then nursing homes even worse. And if we take a step back, what I said is that, many of these patients are in long-term care. And so these are not really the sites that people want to be in at the end of their lives. And hospice can be a way of trying to get them to that better place. We know that most patients, or about 40% of dying patients, experience severe pain, and that doesn't include moderate or mild pain, and that 26% of nursing home patients with advanced cancer and daily pain receive nothing for that pain. We know that most oncologists believe cancer pain is undertreated, and so this is where hospice, this is where palliative care can really come into play. Unfortunately, we know that many people do not enroll in hospice. This data that I'm showing you here is not as current as our question, but about somewhere between a quarter to a third of patients in hospice have cancer. 15% have sort of, I'm just kind of crumbly around the edges, and they have multi-morbid states. There's also heart failure, renal disease, and other things. We know the average length of stay in hospice is relatively short. It's less than 3 weeks. We know that in fact about a third of patients are on hospice for less than a week. That is, they come in, what tends to happen, they come into the hospital, the docs say there's nothing we can do for you, now you go on hospice, they go there and they die less than a week later. And again, that doesn't give hospice the opportunity to help manage their pain, and had we been palliating their symptoms before, we may have made a hospitalization unnecessary for them. So who are we talking about? Again, we're talking about critical illness, these people with serious illness. We're talking about people with a low probability of survival, so that they get a diagnosis of melanoma, they get a diagnosis of pancreatic cancer, and we know that many patients are not going to make it years, that they're now looking at months to years at best, sometimes weeks to months, and that they have a progressive and curable disease. We're also talking about those frail elders who are multimorbid, and really we try and get those people within the last 6 months or less. And the question we often ask ourselves is, would death in the next year surprise me? And if the answer is no, then they may well be a hospice candidate. So for cancer patients, since that's what we're talking about, a cancer patient is eligible for hospice if they have clinical findings of malignancy with widespread aggressive or metastatic disease, they can still be a candidate for hospice if they don't have metastatic disease, but if they have something like a neoplastic syndrome that really hits their performance status, or they've had massive weight loss, those people can qualify as well. Because that says that even though the cancer hasn't really spread everywhere, it's having a total body effect, and that predicts a shortened life expectancy. People can still receive disease-specific treatment if it is palliative, though many of the palliative chemos that people undergo do not seem to improve the quality of life. They really are life-prolonging, and therefore hospice is not going to consider that true palliative therapy. Now, XRT, if I have a big mass and it's blocking my airway, or a brachial plexus phenomenon, radiation may be very, very reasonable in those patients and improve quality of life and decrease pain. And so hospice may cover that. Hospice does not tend to cover transfusions or ongoing laboratory evaluations, because again, a transfusion maybe it makes you feel a little bit better, but it really is a life-prolonging intervention. And the same is true with laboratory studies. We don't tend to do lots of labs, though you can oftentimes ask them to do a lab or two, and they're fine with that. Again, just like with palliative care, hospice improves quality. We know families have a higher level of satisfaction compared to hospital or nursing home. We get better pain and emotional care. We get decreases in hospital transfers, which can be very hard to bear on our patients with end-stage cancer. It reduces overall costs, though I'll be honest, because hospice is a partnership and does not provide for 24/7 round-the-clock care. It does increase family caregiving costs, including time off work, including fatigue. And it's important to note, hospice does not increase mortality. These people are dying, and they die whether they have hospice or they don't have hospice. We know that the longer duration you're in hospice, the better your quality of dying in terminal cancer patients is. So we'd like to get out of that just 3-week window. We know that, again, like I said, it decreases the transfers and improves pain. Oh, somehow I think my slides got duplicated. And that's sort of where we are. So what are some logistics for palliative care and hospice? So you're out in your community and you have patients that you think are going to benefit from palliative care, and you have patients that you think are going to benefit from hospice. So what are we going to do? Palliative care is a little more challenging. Palliative care is relatively new because it is not paid under the same Medicare benefits that pay for hospice. So hospice is a Medicare carve-out, which we'll talk about in just a little bit, and palliative care gets paid for through the normal home health regulations, or through the normal medical, nursing home or home visit regulations, and therefore there's no sort of carve-out money for palliative care. But many home hospices and home health agencies have seen the benefit of palliative care, and so many of them are offering that. So in your community, if you have WellCare and Emeticis and Liberty, some of those programs will have a palliative care arm that includes the social worker and the nurse and the aides, like I mentioned to begin with. Patients can be referred to these programs just like they get referred by home health. They don't give up their doctors. They can still go in, see their oncologist. They can still go in and get their physical therapy. They can still go and see their primary care docs. Referrals to hospice. Again, like I'd said, all hospice care is palliative, but not all palliative care is hospice. Because we need that 6 months or less, we need 2 physicians to certify that this patient has less than 6 months to live. If that happens, and so you can have an attending physician and the hospice physician, then you can refer them to hospice. You have to have a face-to-face requirement, which means they have to be seen by one of those physicians and said, yes, in fact, you do have less than 6 months to live. Now, families can actually refer their loved one, and patients can self-refer to hospice. But if that happens, they then have to get the doc to say, okay, yes, we agree with this. This is okay with us. We believe this patient has 6 months or less. So just so you know, that can happen, though that is not the typical course by which people get into hospice. I think agencies vary in their willingness to provide non-palliative treatments, and so that's where I was talking about the transfusions and the chemo and the radiation. It really is going to depend on the agency and what they're going to provide. So to give you some backgrounds, as opposed to palliative care, which is paid through traditional Medicare, hospice is a Medicare carve-out, and it's part of Part A, which means that if you elect to use your hospice benefits, you are saying that I am not going to be using my inpatient Part A hospitalization benefits. So it's really a one-for-one. And that's why I think this discussion about how do you really not want to come back to the hospital? Now, if a patient on hospice falls and breaks their arm, and they're on hospice because they have lung cancer, well, you're gonna bring them into the emergency department. We're gonna cast that, you know? I mean, we don't want them to die from something other than their cancer. We expect the cancer is what's gonna get them. We're not gonna let them die of a UTI. We're not gonna let them die from something other than the cancer, which we can't cure. And so I think there are exceptions to the hospice waiver, but if the patient or family decides, no, I want to go back, I want to go to the ICU, I want to go into the hospice, then they revoke their hospice benefits, and then their normal traditional Medicare Part A takes effect. Again, the focus is exclusively comfort once they start hospice. So we are doing things to help them be comfortable, and that is really our sole goal. There are usually 90-day certification periods. And then, so it's a 6-month benefit. So you get your first 90 days, 3 months. They look at you and they say, okay, it looks like you're going to die in the next 3 months, or we're starting to get worried because now you're in hospice and we're like managing your symptoms and you're doing really awesome because we've like made it so that you don't suffer and you can now live your life. You may have more than another 3 months. And so then they'll research you for 60 days, every 60 days thereafter. And if you continue to decline, they will continue to research you. So I have had patients, like one patient who was on hospice for 2 years, and they slowly kind of dwindled down. I've had patients who were on it for 6 months. They did really well. They graduated from hospice. So you'll hear people, oh, I was on hospice and I graduated. Well, people get better. We, again, like I said, we're not great prognostication. We don't do that very well. Hospice does not require people give up their main doctors. Many people think, oh, now I can't see my main doctor. What often happens is the nurse becomes the point person, so that the nurses, hospice nurses know so much. And they're able to say, okay, let's take the Lasix, or let's take the morphine, or let's, try a little Ativan, or we're gonna use glycopyrrolate, or there are all these medicines we can use to manage symptoms, and they don't need to see their main doctor because, getting in the car and getting there, all of that is not particularly comfortable. You want to be living your life. You don't want to have to be going to the doctor all the time. So again, I think it's important to remember they don't give up their primary doctor, though they often do not see them as often. Again, it's possible to graduate from hospice if people stabilize. They often can. And it is possible for a person to revoke hospice at any time. I had a patient who thought, I don't know if I'm going to like hospice. I just don't know it's a good fit for me. They try it for a week. And then if they don't like it, fine. I revoke my hospice benefits. I go back to what I was doing. It is still possible for people to go to the hospital, as I said, if necessary, though oftentimes we hope it's not necessary. And if they have uncontrolled symptoms, instead of going to a hospital, which does not do a very good job of controlling symptoms, they often go to inpatient hospice. We'll talk about that in just a little bit. So to understand about sort of how hospice gets paid for, which I think as providers, you guys need to understand, what does hospice look like? It is a capitated system. Now, half of them are for-profit, which always sits a little uneasy with me. So if they don't pay for things, they make money. They, on average, receive about $162 per day per patient, which means if a patient needs more than that, in terms of either an aid in the home or an expensive medicine, or they have to come into the hospice home, which again is going to bump the bills, suddenly their patient's costing them $500 a day. In 2016, that reimbursement went up for the first 60 days and then went down after that. And so that, unfortunately, I believe creates a disincentive to keep people on hospice longer. So now we only want people on hospice for 60 days, even though I've just told you that the longer you're on it, the better your symptoms tend to be controlled. Payments are distributed by a third party that Medicare appoints as its intermediary. In North Carolina, at least as of last year, it was Palmetto. And Palmetto dictates what clinical findings equate to a 6-month diagnosis. So that this organization says, okay, if we had renal function, a creatinine greater than 6, or a BUN over 100, or a stage 4 heart disease, an EF of less than 15%, all qualify you for hospice. Tomorrow they could say it's an EF of 5%. They could say it's creatinine of 9. And so those are the people that set what clinical findings physicians need to see before they can refer. Hospice, it's important to remember, pays for all medications related to that primary diagnosis and all of its associated conditions, but they do not pay for unrelated conditions. So if I have bad heart failure and I have cancer and I go on hospice for my cancer, they're not going to pay for my heart failure medicines. This is important for our patients who are on dialysis who get cancer, because they can continue their dialysis, which is a life-prolonging intervention, while we know they're going to die from their cancer. However, if they wanted to go on hospice for their renal disease, hospice would not pay for them to have ongoing dialysis. It would be expected they would stop dialysis, and their life expectancy would be on the order of days to weeks. So what does hospice provide? It covers 100% of nursing care, which tends to be about 1 day a week. Sometimes it can be more, but it's usually about a day a week. It provides symptom assessment, skill treatments, and case management. That includes nurses, social workers, and more recently, some physical therapy. There's a 24-hour on-call service. You call them, they call the on-call person, they get what's going on. They call the on-call person, that person calls you. They give you recommendations to help manage whatever the symptom is, the problem you're having. They call you back in 30 minutes, and then they say, okay, we'll send somebody out. And so they will try and have the family manage most of the symptoms that the patient is having. But if a nurse needs to come out, a nurse will come out. They provide durable medical equipment, so a hospital bed, they provide a bedside commode, they can provide a Hoyer lift, they can provide oxygen, so any of the kind of medical equipment that you need. In addition, they can provide aid and homemaker services, so people who need baths, people who might need a little respite care so that the wife goes out and they come in and they can make a meal for them, they'll do that. They'll do physical therapy, but it's really just to help them not get stiff. The goal is not to recover. The goal is just to maintain or to prevent decline. They provide a chaplain who is specifically skilled in end-of-life issues. So many, you have your faith-based, you have your faith partner, you have your spiritual leader, but many of them, they're dealing with the whole spectrum of life, from your baptism to your marriage to the end. And sometimes it's nice to have a chaplain who's intimately aware of the struggles that people and families go through at the end of life. And they also provide bereavement support after death. So an associated condition with hospice is you need one of the 3 following criteria. The first one is it is a condition that is caused by that principal diagnosis, or it is a condition that is made worse by their principal diagnosis. That is, you had depression, but now you got pancreatic cancer, so you're really depressed. And it is a condition that on its own impacts a person's prognosis. So for example, if my depression is going to prevent me from taking my meds, it is considered an associated condition. So in some ways, I would say a person's heart failure might be exacerbated by some of the medications that we're giving them to manage their cancer. That might then be considered an associated condition, and hospice may or may not pay for some of those medicines. So in summary, palliative care, not limited to last 6 months of life, may be combined with curative disease-specific treatments. We can give it in hospitals. That's where it's mostly given these days, though now we're starting to provide it more out in the communities, and it really varies on what kind of services are available. Hospice lasts 6 months if the disease follows its expected course. Really, it's palliation only. You can provide it in many different settings, in homes, in nursing homes, in assisted living, and in hospice homes. And it's very much a defined set of services that it provides. I told him it wouldn't kill him to try to be nice once in a while. I was wrong. So, last but not least, what resources are available to your patients and families to learn more about palliative and hospice care services? So if they have cancer and they're here at UNC, we have something called the Comprehensive Cancer Support Program, or CCSP. They can be referred there in addition to their cancer treatment. There's also an outpatient symptom management program, which is really sort of a palliative care program that is at the cancer hospital. There are these local home palliative care programs that I've talked about, and the local communities will often have supportive care groups. So if you contact like the area on aging in your area, they may have supportive groups for patients who have end-stage families of patients who have end-stage cancer, or other sorts of support. These are some resources, so these links should be active. The North Carolina Palliative Care Resource Guide is listed by county, so every county has the resources available in those counties. And that includes, and the AHC also has some resources available. If you're trying to think about, gosh, is my patient hospice appropriate? There is a website called eprognosis.org, and you can actually try and figure out in general, what is the average expected lifespan of a person like my patient? There's also a Go For a calculator, which is a calculator that calculates how likely you are to have a good outcome following resuscitation. So that is, if I die, how good are they going to be at shocking my chest and bringing me back to life in a place that is a good outcome, not vegetative state. And then if you have patients with hard to control symptoms, I highly recommend the mypcnow.org. They have series of fast facts, it's a palliative care now, and they have series of fast facts that are around a lot of different symptoms that are difficult to manage. So nausea, vomiting, constipation, diarrhea, dyspnea, pain, the whole gambit of symptoms that people have. Like I think you can find hiccups, or what's the right opiate in liver failure, and all kinds of things. So if you're looking for resources for hospice, there's a lovely app called Hospice by the Bay, and it actually has, at least it's for the Bay in San Francisco, but it has a lot of resources for clinicians and practitioners, and it also has the criteria in California for what qualifies for hospice. You can also consider a informational visit. So if you think, I got a patient who is getting near to hospice, but maybe they're not quite there yet, and you want to kind of inform them about what hospice might be able to provide given where they are, you can ask the local hospice agency to go out and just provide an informational visit to them. And they'll sort of talk about, okay, this is where you are, this is how we're going to know that will be helpful to you, and these are the kind of services that we think we can provide you. And I especially think that's important if I'm worried they might suddenly decompensate. So if they're doing pretty okay and I know it's kind of this slow dwindle down, well, fine, maybe I don't need to do it. But if I'm worried they're going to do okay and then sort of fall off a cliff, maybe I want to get this informational visit because they may need to go to inpatient hospice. And so inpatient hospice is a hospice unit. It's usually a standalone building. Most hospices, they either may have one of their own. So for example, in Wake County, there's Transitions of Wake. We at UNC have one, Duke has two, so that we have these standalone buildings for if symptoms are hard to manage, and we have done our best to up-titrate whatever medicines we're doing, and they're still having difficulties in their home, we can send them to the hospice home where they have 24/7 nursing, they have physicians who round on them every day, and again, just like an ICU might manage their heart failure, they're going to aggressively manage their symptoms. And so if you think they're going to need that kind of high level end of life, they're going to have hard to control symptoms, getting them referred earlier, at least to have an informational visit, may be helpful. And then you have to think about who will be willing to sign orders. Are you going to, would it be their cancer doc? Would it be someone else? So again, if you're considering a hospice referral, like I said, ask yourself if they have uncontrolled symptoms. Do they have an inpatient hospice that's affiliated with them or not? If they don't have uncontrolled symptoms and they have family, oftentimes you're going to do home-based hospice. If they don't have uncontrolled symptoms but they don't have family and they have Medicaid, then you can often do hospice through an assisted living or a skilled nursing facility, because Medicaid will qualify you for long-term care, and that will get them into a nursing facility or a assisted living. So that in general is the talk. Thank you for your time. I like this cartoon. It says, "So you're to be my escort to the great beyond, Dick." Yes, and I am indeed, my dove. I don't know what sort of company I'll be, dearest. Everyone says I've lost my mind. It's not your mind I'm here for, Lacey. It's your soul. Oh my, I like that. Are you flirting with me, spirit? It is possible. We don't know what I think is going to happen after we go, but I do think it's important for us to try and palliate our symptoms of our patients while we have them. These are some other resources in case you are interested in looking them up, and here's some more resources out there about the Medicaid benefits and Medicare benefits and various fact sheets. So thank you so much for your time.
Great. Dr. Kistler, this has been fantastic. Thank you so much. I want to remind our audience that you can now go ahead and share questions with Dr. Kistler. If you already joined that poll everywhere by responding to the first question there, you can just go ahead and start texting those questions in. Again, and if you haven't joined yet, just send the letters UNCCN to the number 22333 once. You'll get a join message, and then you can go ahead and start sharing those questions. So first one already, does Medicare cover palliative care?
Right. So not in the same way it covers hospice. So Medicare will cover palliative care like it covers a traditional doctor's visit. So Medicare, whatever plan that you have, and there are like a bazillion plans, will pay a certain amount in terms of home care. So there are billing codes through, like you bill through traditional Medicare, that you can bill for either a home visit, you can bill for a skilled nursing visit, or you can bill for an assisted living visit or a clinic visit. And so it'll cover that as like a single visit, or it will pay for home health. So home health, which may have home palliative care associated with it, will get covered usually for 6 visits, and will include some type of nursing or physical therapy that they have to require to qualify for home care. And if they don't sort of improve, oftentimes palliative care will say goodbye after a period of time. And so getting palliative care is currently a challenge. It is partially covered. Some of the services are covered through Medicare. Some of these home health agencies will say, well, we'll continue to stay involved. We'll continue to provide palliative care, knowing that eventually they'll transition to hospice, and that way they can capture them once they sort of go through hospice.
All right. Can you elaborate on graduating from hospice? What has to happen for that to be possible?
So they have to get better or not get worse. And so that there are sort of metrics that you can use to tell if a person is getting worse. So we will sometimes do like measurements of their arm circumference. Sometimes we can't weigh these patients. I mean, if they're continuing to lose weight and we can document that, that's great. But sometimes we'll have to do arm circumference, we'll do albumin. But if people have been on hospice and they haven't, for like, let's say, lung cancer, and they aren't needing any more oxygen, they aren't needing any more morphine, they're up and like, baking cookies and like doing their lives, and functionally have continued or even improved, then hospice will say, look, they're not dying, so we're not going to cover that anymore. And so what they'll do is they'll have a 3-month visit. After that 3rd month, they'll all meet and have an interdisciplinary team meeting where they'll say, okay, this patient's looking good. We're not entirely convinced they're going to die in the next 3 months. They will then see how they're doing, and they're like, look, they're even better. And so at that point, they will say, we're going to graduate you from hospice, and you're going to go back and you're going to see your main doctor. And this can be a challenging place, and this is oftentimes where my home care program gets involved. And there are home care programs in most of the counties out there. They're usually more private pay programs. Ours is through UNC and for UNC patients. But what will happen is then they will go and they'll resume their care through their normal doc until they start to decline again. And once they start to decline, at that point, a nurse practitioner from hospice will come out and evaluate them and decide whether they're actually worsening or not. So we had a patient who had just terrible renal failure, and she was having heart failure exacerbations all over the place, and we couldn't get that under control. And we got her on hospice, and they were able to just kind of like balance everything out. And so she was able to graduate, came back to us, we continued to care for her, got a diagnosis of cancer, and even though it was like, lung cancer, and she was totally gonna and didn't want treatment, her goal was, I just want to live my life, that's why I want hospice in the first place. we had to get their nurse practitioner to come out and certify her to say, oh yes, in fact, she does have 6 months left to live, and she lived another 3 months or so. And so that will help you. That's sort of what you have to do to graduate from hospice.
All right, thank you. So we're so thankful to our audience and all of those community college students who are out there today listening, or maybe listening to the recording later. What advice would you give to them as they're looking at different healthcare options as far as careers within the healthcare system? What sorts of character traits or interests would lend one to really be successful and enjoy a career that involves palliative care and potentially hospice?
I think that one of the best advice I got when I was going into medicine to begin with is you have to love the best of it. That's important. Absolutely. You got to love what you do, but you also have to be able to tolerate the worst of it. And so there's something bad about every job out there. There's no job out there that is going to be 100% like puppy dogs and roses and, rainbows and everything. No, there are always cloudy days.
I'm still looking for that job.
That's right. There are always cloudy days. And so I think that if you can tolerate that, for me, I got to sign so many friggin' forms for like certifications and all this kind of mumbo jumbo to get their DME and medical equipment and everything. And I can sign a form. Like, I'm okay with it. I don't like it. I don't enjoy it, but I will sign a form and I can sit down and do that. But there's some people who, they hate that. They hate documenting every little widget. Yeah. I'm going to say that we've moved into a high documentation field just in general, so you're not going to be able to get away from some of these things. Mm-hmm. But I think if you love what you're doing and you can tolerate the worst of it, for me, I love patients. I love stories. I love caring for people. Like, I'm not an organ-based person. I'm not a person who thinks about, their kidneys or, their lungs. Like, it's all part of a person. And that person is a person in a community. And so that's what interests me. And so I think people who like to care for people would do well in palliative care. Mm-hmm. They do well in hospice because they're caring, because that's really the focus. Mm-hmm.
And I would guess, as opposed to, some in healthcare who may be thinking of success in terms of, I saved this person's life, but this is about the quality of each day.
That's right. And what I would say is, for me, success is I have honored their values to the best of my ability. Mm-hmm. And when I can do that, it's a win. Mm-hmm. So we all die eventually, and we're all going to have to look that in the eye. But can we honor our patients in the act of caring for them in a way that is congruent with their values? And I feel if I can do that, then yes, it's a good day.
I like that. Well, we've got another question. Often people do not have family or do not recognize hospice as an option or their need for hospice care. Yeah. Where should I start if I suspect that somebody needs, and I'm going to assume, hospice care?
Yeah. So the unbefriended person, a person who really doesn't have a lot of social care, that can be a hard place to be, because hospice is going to want somebody in the home. They're going to want, it doesn't have to be the same person. So, you might have like all your aunts and uncles or your cousins or your kids and all their kids. Fine. As long as there's somebody who's in there to help you. Mm-hmm. If you can pay for an aid, so you've got a Medicaid, PCS, a personal care service aid, then that person can count. Knowing that if their symptoms get really bad, they're probably going to need to go to the hospice home. So that can be for people who don't have families. Hospice also provides, so if you don't have Medicare, right? Like, what do you do for hospice for people who don't have Medicare? Like, I'm sorry I didn't address that until right now. What you do for those people is you find a pro bono hospice. All the for-profit hospices, as part of being allowed to be for-profit, have to spend a certain amount of their money on charitable care. So when you have your 50-year-old with suddenly got cancer and you've tried everything and they're going to die from their cancer, at least they can get hospice. The VA made a promise that no veteran shall die alone. So all vets are eligible for hospice regardless of what their condition is or service connectedness. So that's something to remember. Now, how do you help people realize that hospice, it might be time for hospice? I think sometimes talking about the actual care they've gotten, the actual things that they've been through, and saying, these are your options. And let's just talk about it. If I push an agenda, if I push hospice, right, I'm going to be the death doctor with my black cloak, and I'm going to have black crepe in the room, and nobody's going to be on board with that. But if I push it as, how are you doing with everything that we're doing to you? We just put you in an ICU and put you on pressers, and we put the breathing machine down. How was that? And if they say, oh, that's fine, I don't mind that at all, I don't care, then great. Maybe they're not ready for hospice. People die not on hospice because they don't want hospice, and that's okay. But it's really about those people who are like, I hate the hospital. I don't ever want to come back to the hospital. I don't know why they did that to me then, and I don't want them to do it to me again. Mm-hmm. So again, talking about the past, talking about what's important to them, it can become relatively obvious that this is what they want.
All right.
Well, so that's what I would say.
That's very helpful. Well, I want to thank our audience, and thanks for these great questions as well. Just a few things in terms of, that I want to go over with you before you leave today. Online lecture evaluation, a link will be sent via email from GoToWebinar 1 hour after the conclusion of today's lecture, so you should be getting that. If you registered for a group to view the lecture, so if you're, for instance, if you're in a classroom, please forward the evaluation link to those who are watching with you. So typically your professor would go ahead and she or he would share that link with the class so that every student can fill out that evaluation. We really do look at these evaluations, and these are an important part of our program, so we definitely hope you'll take the time to do that. The evaluation will remain open for 1 week, and your feedback really is important to us. So please take just a couple of minutes to do that. We want to thank the North Carolina General Assembly for their generous support of UCRF, otherwise known as the University Cancer Research Fund, and the UNC Lineberger Comprehensive Cancer Center. We also want to thank the North Carolina Community Colleges for their partnership in this program. Specifically Renee Batts and Catherine Davis. We want to thank the UNC Cancer Network team, including Dr. Tom Shea, Mary King, Veneranda Obore, Alan Brown, and Jean Sellers for all the hard work they do to make this and other series possible. Our next community college program will be Caring for the Patient with Cervical Cancer with Lynn Phillip, and that will be February 26th, 2018 at 1 p.m. So we hope to see you for that. If you would like to find out more about that, you can go to www.unccn.org/cervical cancer and get more information about that. Thank you so much for joining us today. If you want to, again, ask us any questions or call us with a question, we're at email unccn@unc.edu, phone 919-445-1000. We're on the web at unccn.org. You'll find almost 200 different recordings, including several from our community college series. Lots of information there, as well as plenty of details on upcoming events. Thank you so much. Have a wonderful afternoon. Thank you for being with us today.
Thank you. Thank you for having me.